Okay, thanks very much. This was an opportunity for us that when we submitted to the symposium here to actually introduce a little bit this concept of rehabilitation. And I don't have any major disclosure except I'm president of this foundation that we set up for. Now, the objective of today is very much reviewing the pathophysiology of stress in a very short concept of surgery and cancer, and then talk about really the issue of postoperative complications, which are important from our point of view. And then introduce this concept of rehabilitation, which is in a way is a sort of novel concept, and show you some of the work that we did at McGill. This is a classical cartoon that indicates what actually happens with the surgical stress. You're quite familiar with that, of course, and is a cascade of events from the point of view of not only inflammatory response, but also with the metabolic aspect, which really set up the scene for what we call in then the issue of insulin resistance. Now, what about cancer and metabolism? I really try to explain in few concepts what actually happens to the metabolic changes. And you can see there is only an increase in energy demand. In fact, if you measure protein turnover in the patients with cancer, you see there's a huge turnover in terms of metabolic turnover, protein and also energy and carbohydrates. And therefore, what is interesting, there is a huge dependence on sugar. So, and then, of course, other substrate taken for the protein. So the patients have an interesting aspect of really energy metabolism, probably related to the tumor or related to the high response to tumor itself. So this is quite an interesting slide because came in 2008, the American Journal of American College of Surgeons identified that they looked at the NSQIP, as you probably know, is the National Surgery. It doesn't work anymore. It used to work, and then now it stops. Yeah. Is it? Okay, you have to press probably. Okay. Yeah. All right. Doesn't seem. Oh, sorry, I gave up. And basically, what is the National Surgery Quality Improvement program identified a list of, let's see, 11 procedures in general surgery. It's interesting enough, the colon colectomy and small intestinal resection were the large numbers, but actually the one where the largest number of adverse events, almost 29%, and the proportion of excess or length of stay, indicating very much that such a most common operation is associated with such a high intensity of complication and event. So that's bring us to the reason why, to some extent, we are studying this this operation because of in fact, the high incidence of morbidity and adverse event. Is that one better? Yeah. This one. Yeah. Yeah. As you can see here, 29%. And for other surgery, like take pancreatectomy or take, for instance, liver resection, which is a small amount, you can see, except for pancreatectomy, actually relatively smaller incidence. So there is something about colon resection which is quite important to discuss about. Now, what is interesting, 5 years later, this was again published in surgery, and you can see still remains high despite all the advances in minimally invasive surgery, surgical care, and anesthesia, and so on. So I thought of probably starting looking at what are the risk factors for prolonged recovery. Now, why the patient take long to recover? And this is a study published in 2004 where they looked at preoperative physical performance, serious postoperative complication, and depressive state. And they look at some functional score, time up and go, functional reach, hand grip strength. And it's interesting, we always thought as a physician that if your album is low, or creatinine, or cardiac failure, or age, you might in fact have some risk, but in fact it's not true. The most two important, apart from serious complication, where you can see independent factor was physical performance status and geriatric depression. So mind and body, quite significant. So in elderly population, seems to be these are very important factors and not other factors. Now, This came in annual surgery, where they looked at optimizing surgical care of colon. And the factor they predicted complication was age and BMI, before other factors, even duration of surgery. And the comment in the discussion, which says surgeon will have to operatively approach an older group of patients with multiple preoperative comorbidity, is clear from this data that preoperative health, preoperative, and functional status as well operative approach contribute to shorter outcome. So there is this feeling very much the preoperative state is very important. Look at the American College of Surgeons risk calculator, which was recently published in 2009, where they look at 15 variables predicting high risk. There are non-modifiable and potentially modifiable. Again, functional status, BMI are potentially modifiable. So it brings us to the question of very much where we should consider. I'm not going to go in deep, but probably to this society where, in fact, the nutritional risk screening over 4, as you know, is definitely the number of complications increases. With preoperative nutrition and then no preoperative nutrition. As you can see, definitely there is a major impact of nutritional as well. So physical and nutrition. So who are these people at risk? Personally, I think that we can identify these people here. And the reason, I believe, is this limited physiological reserve, which is probably is one of the pathophysiological aspects of the difficulties where they can come up back to baseline the moment you lose this reserve, and how we can help them. So, and it goes from the elderly, the frail, nutritional status, obese, and then cancer, depressed, anemic. So what do we actually do now in our colleagues, surgical colleagues do at the moment? So I call it functional reserve. What actually we do for these patients? And basically it's a pre-existing medical condition, functional capacity, and psychological status. I bet there is no place in this nation or in North America where actually the psychological status is addressed seriously, preoperatively. And I'm not sure the functional capacity is addressed properly in any preoperative clinic and so on. Yes, we are excellent doing pre-medical condition. We fix the diabetes, we fix maybe the anemia, even that is a big issue, and probably fix the rest, which is... So pharmacological and procedural intervention. When we come to nutrition, physical and mental, I would say they're probably zero, almost nothing. And at least in my institution, I bet in many, many institutions. And so maybe a little bit of nutrition, but you really have to be malnourished before somebody intervenes. So for the functional reserve, which I think is very much a constellation of all these aspects, I think that is what could be an important target. So if you actually look now what actually happens in surgical, call it rehabilitation, there are only two, I would say, established rehabilitation. One is the cardiac rehabilitation, post-cardiac surgery, and the second one is orthopedic after hips and knees. There is no rehabilitation, does not exist rehabilitation after general surgery. Go home, try to do what you can, don't lift, eat, and so on. Otherwise, there is nothing else. So why don't we do anything about it? Because I think the patient post-operative is tired, is not able to actually function properly, is depressed, is waiting for diagnosis. Why don't we use the preoperative period? So the idea is that if you have this functional ability, we are here. If we have a surgery, we drop, we know. At least for the 3rd, 4 weeks, any surgeon will tell you, the patient come to my clinic after 3-4 weeks and they complain, they're tired. And then there is the process of recovery. And this is where sort of convalescence or rehabilitation, we call it, is actually acting. And you return to baseline after a certain time. Some people return faster, some people take a long time. But what about if we are thinking about increasing this period of time? The patient are waiting anyway. For diagnosis, they always wait minimum 3-4 weeks, anywhere. even in the States, where they claim they have the operating. Because it basically is diagnosis, assessment, CT scan, and so on, staging. And then you drop it, but you won't drop it at this level. You will drop it much closer to baseline. And then, of course, the phases rehabilitation will increase. So, principle is interesting. So, why and what and why rehabilitation? Well, let's use the preoperative time to optimize the physical, nutritional, emotional, medical, and pharmacological condition. It's actually a salient time. It's an opportune time. Patients are waiting for the surgery. They're anxious. They don't do anything about it. And with the intent to improve the postoperative functional capacity, of course, and hopefully, the idea is to impact on the medical and surgical comorbidity, on the understanding that there is a very good relation between preoperative physical condition and morbidity, postoperative morbidity. So, now, is there something done? Yeah, very little, some few publications. There are very few meta-analysis, one meta-analysis, two meta-analysis, where they look mainly in the orthopedic population. So in fact, they saw the preoperative inspiratory muscle training on pulmonary complication was very positive, and the same preoperative exercise on the length of hospital stay. But as you see, is not really very after replacement surgery. So the majority of work is done in the orthopedic. The second came in physiotherapy recently in 2014, and they look at 17 randomized controlled trial, not very good quality, 13 orthopedic, 1 abdominal only, and 3 cardiac. So the majority orthopedic. As you can see, definitely length of stay, physical function, there is an improved postoperative, but there are equivocal benefits on fitness and complication. So there's a fair amount of work to do on that. So I'll show you today what we have done over the years. It all started with this pilot study where we looked at the VO2 max preoperative colorectal surgery and did a two level, low fitness, 50 years old on average, and BMI. So they're home base, 7 times a week, heart rate, maximum reserve, and bikes for 4 weeks before surgery. And we had approximately not bad overall compliance. And by 4 weeks of rehabilitation, we actually increased 15% of VO2 max, which is quite remarkable when you think about this corresponds to 1 to 3 METs, metabolic equivalent. So based on that, we thought that exercise was great. So we actually started a randomized control trial, which was published in 2010, where we looked at intensive exercise versus walking and breathing, giving some general instructions. And then we follow later on, because the report were not really impressed with intensive exercise, patients were getting tired. We then went to a pilot of a multimodal prehabilitation versus historical control. And then we looked at prehabilitation nutrition, which Chelsea is going to say, and then a prehabilitation versus rehabilitation, understanding that we want to give to patient the advantage to have something, otherwise it will be biased in a sense that because exercise is not a tablet, is not a placebo, is not a pill, to give a behavioral changes, patient can interpret differently, it depends on the group they are. So what do we use, and what we use is a functional walking capacity. You use the 60-minute walking test. It's a very objective, it's reproducible, it's well used in a cardiac, in a pulmonary. We are validated in surgical patients for transplant as well, and essential to every day. What is important for a patient is to walk, mobility, because if they walk, they can go shopping, they can go to the bank, they go to see friends, they are mobile, and they are independent. So that's what it means for the patient. So we are moving from what is surgeon-centric outcome to patient-centric outcome. What's actually important for the patients. And that's why the reason why we use that is a validated measure of surgical recovery, and it's cheap. And a minimal important difference is 20 meters. It's the smallest change in outcome, which is over the error, perceived as beneficial by patient, in this case undergoing colorectal. And that's our predictive Canadian norm. So in our first study, when we reanalyzed the patients, what we found that basically there was a third group who actually improved in the prehabilitation phase, preoperative phase, and actually they stay above 20 meters. There was a group who didn't change, but the group who actually deteriorate over 40 meters in the preoperative period, they actually remain low, and they actually higher complication. So that indicates that definitely prehabilitation could in fact keep patients in a better shape or less complications. Now, what is the message from this? Was that basically intense exercise in this population was not sufficient. 1/3 of the patients deteriorated, and also not only, but in the walking group, did much better than the bike group. Why? Poor compliance, very important. Anxiety and depression in 20% of the patients. And then lack of social support, that's what important is the family contribution. But no nutritional intervention. We didn't think about nutrition, especially in this population at risk. So then we decide to maintain the aerobic resistant exercise because there is sufficient evidence in the literature about the impact, the effect of an exercise. We want to maintain that one, which Selina was going to talk about. But what we did, we actually identified there were 1/3 patient at risk. We decided to actually go and supplement nutrition in an anabolic windows fashion that we discuss about. And there was the issue of anxiety reduction, not to have a psychologist to change behavior, because in 3 weeks you don't change behavior, but to help them, strategy to decrease anxiety in that period of time, and also motivate them to participate in the program of research. So this was a multimodal, that's why we call it 3-modal multimodal. And that's a randomized control trial. And then was a multimodal, which was preoperative. So we told them, you're going to receive it. And then we did, at this point, we did here, assessment, 60-minute walking test, grip strength, SF36. And then we actually start to continue. What most important was here. And the second group, we promised a nutrition and exercise and strategy, but starting immediately after surgery. And we basically gave a booklet, so they monitor everything. We gave a pedometer, so we know exactly what they've done. And at the same time, we have a telephone call every week to know the progress and motivate the same way. So everybody was seen in the same way. So as you see, the median duration was 24, which is approximately 4 weeks before surgery. And then the component were these 3. So what we saw, we expected, like the pilot, this is the preoperative phase. The prehabilitation group went up by 20 meters, and with a 58% in this population. And then there was a drop, and then up again at 8 weeks. The group who actually deteriorated was in rehabilitation, and then, of course, they continued to rehabilitate despite the intervention here, and then they pick it up. The historical control, which no receive and no rehabilitation, and no surgical, no rehabilitation, no prehab, as you can see, they are down and they remain down. So shows very much that basically, if you don't do anything, there is a deterioration in functional capacity. So change in preoperative, we have 54% above the baseline, which is meaningful, clinical meaningful in a large population. And then, of course, in postoperative, at 8 weeks, the same, compared to the group, the rehabilitation group. So definitely there was a beneficial effect, and we had a very good, actually, compliance. Believe it or not, patients were actually participating. Now, then we said but there is a large population with large variation. Why we don't look at patients who are probably more at risk? So we looked at the predict value in this population, and we look at the less than 60%, which in our population, large or almost 300 patients, we found was around 400 meters, which actually makes it clinical significant. And what we found that was interesting is that the population of less than 60% not only were older, as expected, but actually they start with 320 meters, which is approximately 50% of the predicted value. And they increased to 160 meters, and the difference was plus 48. But those who are actually above 60% were actually, when you say fit, they probably gained very little. And this is show that probably this is the group we want to spend our energy, because there's the one who actually respond easily to the prehabilitation. So all these people had the prehabilitation. So and also the American Society of Anesthesiology risk assessment, higher. So that is an interesting observation. We're just working on it. Not only that, the gain that was achieved in the preoperative period continue also postoperative period. As you can see, over 70% gain over 20 meters compared to the other group. And the same also, again, at 4 weeks. So it shows that there is a certain reserve which is probably maintained and continue in the postoperative period, which could be a useful asset. So why really makes sense a 6-minute walking test? So what? So, and I said that there are some very good, but let me go back to this concept that sometimes clinicians have a difficulty to grasp. And it's all about the independence mobility. So if you have a 6-minute walking distance, so 320 meters, you go at a speed of 0.8 meters per second, which only allows you to go 2 lanes. But if you go up to 170 meters, is 1, and this is 400 meters, which is considered criteria in an elderly population of mobility and dependency, then you really cross 4 lanes of traffic, which is a lot, while the life is green. For the patient, it's important. So if I say what actually happened is that this one in the rehabilitation will probably stay same and remains the same. But this is going up and is able to actually go almost 1 meter. That's in the rehabilitation period. So the primary findings are definitely proof of concept. The preoperative multimodal intervention could actually work. It's feasible. Now, definitely is a moderate vigorous activities patients actually do. We have a reason, and Selina is going to talk about. And the lean body mass also, we have indication, preliminary indication, the lean body mass increases. Now, those with low baseline reserve, where we probably need to put all our money, is definitely increasing functional capacity. And that's probably the one who are more risk of postoperative. That has to be validated with a proper randomized control trial in large population, looking at morbidity and so on. And we will ultimately, Selina is going to talk about, actually supervising hospital exercise. That is feasible. And also, patient recover at 4 weeks. That means you don't have the drop that you can see for weeks and then could stop at 4 weeks, and which is actually return to baseline at that point. Thank you very much.
So nutritional care for colorectal surgery. We have 2 major tasks that we need to accomplish here. 1, we need to avoid undernutrition. 2, we need to support anabolism. Those are the 2 major tasks that we need to accomplish. Now, undernutrition occurs as a consequence of inadequate food intake and or metabolic alterations or an inflammatory response that can affect nutritional status, that can affect nutritional requirements. Now, our colorectal cancer population before surgery are at risk of undernutrition. They have an inflammatory response, either triggered by the tumor itself or a systemic response to the tumor, and they also have metabolic alterations before the surgery, including things like perturbations in glucose metabolism, acceleration of skeletal muscle catabolism, and alterations in amino acid requirements. For instance, if we have this inflammatory response, we're going to trigger acute phase protein synthesis. In order to synthesize acute phase proteins, we need aromatic amino acids. If the patient does not ingest aromatic amino acids to synthesize fibrinogen, where are they going to get the aromatic amino acids? They're going to catabolize more body tissue. So this can accelerate lean body tissue loss. So even before surgery, we see this inflammatory response. We see these metabolic alterations that can put the patient at nutritional risk. So the only way we could kind of recover here so that our patients are not really malnourished before surgery would be to have an adequate nutritional intake that meets this demand. And are our patients eating well before surgery? Do they compensate for this, the metabolic alterations and the inflammatory response? No. Here I have 4 studies relatively recently published looking at colorectal cancer patients going for surgery. And we used, I have a pointer here. Either the PGSGA or SGA is used as an assessment tool for these patients. And the pattern is pretty similar here. The trend is quite similar. If you look at before surgery, our colorectal cancer patients have symptoms that make it difficult to eat. About a quarter of patients in this first study had symptoms like diarrhea, constipation that affect food intake. And then if you look at the two categories, nutrition risk and severe malnutrition, in the other three studies, you'll see that at about a third of the population in these studies were at risk of malnutrition or severely malnourished. So you can see that before surgery, our patients do have an inflammatory response, they have metabolic alterations, and they don't eat enough. And that puts them at nutrition risk before surgery. And then what we do is we hit them with the surgery. So now we have the surgical stress response that's going to stimulate the release of counter-regulatory hormones and cytokines and induce metabolic changes. Again, we see perturbations in glucose metabolism. We see protein catabolism. So now what we have is these patients who have a stress-induced inflammatory response and a stress-induced metabolic changes. So again, now we have after surgery, are these patients eating adequately to offset the effects of metabolism and inflammation on nutritional status? Well, from our experience, they really are not. In this study, we looked at our colorectal cancer patients, and we measured their food intake after surgery. So we looked at how much energy they're taking for the first 3 days, and how much protein are they consuming for the first 3 days after surgery, with and without oral nutrition supplements. And we considered patients met 100% of their requirements if they consumed 25 calories per kilo, or if they consumed 1.5 grams of protein per kilo. And we considered 60% of those requirements being minimally acceptable. And why we use 60% is because if you look at practice guidelines, it usually states that if a patient cannot maintain oral intake for about above 60% of requirements, they need to start nutritional support after about 10 days. So we use 60% as considering to be minimally adequate. So are our patients eating well? Well, in terms of energy intake in the first 3 days after surgery, they're not doing too badly. With that oral nutrition supplement, they're able to meet this minimal acceptable intake. But what about protein? Not doing so well, not so hot. So in this case, they're not even able to meet that 60%, that minimal intake for all 3 days after surgery. And to make matters worse, on the second day after surgery, we asked our patients with a food satisfaction survey or a food access survey. One of the questions said, choosing the right food is difficult. There isn't enough information. And 70% of those patients said no. So that means that those patients with that inadequate protein intake believe, no, it is not difficult to choose the right food. I do have enough information, which is a little bit scary to me because that tells me that the patients believe that they are making the right food choices, even though we know that they're grossly inadequate in protein intake. So that's a little concerning. So if our patients are meeting, relatively adequate energy requirements, is it really a concern that they are not meeting protein requirements? Yes. This is a study done by Dr. Schricker's group in Montreal. And what he did was randomize patients to receive either a dextrose infusion, a hypocaloric dextrose infusion, or an infusion of dextrose and adequate amino acids, hypochloric dextrose and adequate amino acids. And this infusion started at the time of surgical incision and continued for 2 days. So it continued straight for 2 days. And on the second postoperative day, they looked at stable isotope kinetics. And what they found is that if you look at this leucine balance here, this is whole body protein balance. It's this difference between protein breakdown and protein synthesis. So if patients have a positive whole body protein balance, they're in an anabolic state. If they have a negative whole body protein balance, they're in a catabolic state. Now, if you look at this whole body protein balance, you'll see that amino acids are absolutely required to achieve anabolism. And even though, and I think this is really important to understand, that the second group received hypochloric dextrose for 2 days, and it was not enough to achieve anabolism. They're really quite catabolic there. So we absolutely need amino acids to achieve anabolism after surgery. So yes, it's a really big deal that our patients are not meeting even minimally acceptable protein intake. We don't know exactly how much protein patients need after surgery. That's not really widely accepted in the surgical literature, but we believe it's about 1.5 to 2.2 grams per kilo. So that's the next thing we really need to look at. So now let's go back to the preoperative period a little bit. What do our practice guidelines say? Well, if we look at ESPEN, it tells us that severely malnourished patients need care before surgery. We should give them nutrition support. If we look at the ARAS guidelines, it tells us that our severely malnourished patients, they also need support, and in this case, it's recommended oral nutrition supplements. Now, more recently, and I really like this, the Surgical Summit Consensus, and I'm going to read it, stated that the purpose of preoperative nutrition is to prepare or optimize the patient for surgery, not necessarily to replace deficits. This is a whole new ballgame. So now we're not just correcting deficits, we're not just treating the severely malnourished patients. If we think about it from this perspective, what we are trying to do is optimize the patient so that they are never malnourished. So they go throughout the whole perioperative period without having to correct any deficits. They remain nourished throughout the period. And this is where prehabilitation fits in really, really nicely. So Dr. Carley kind of already explained how prehabilitation works, so I won't get in too much. But what we do is we recruit, oops, this is not my pointer. We recruit our patients at their first visit with their surgeon. We recruit them into the study, and then about 4 weeks before their surgery, they get this trimodal intervention. And this intervention involves an exercise program. They get resistance exercise, aerobic exercise tailored to their needs. We give them nutritional counseling and whey protein supplements to make sure they meet their dietary needs. And we give them stress reduction strategies. So they take this program home and they use this program for 4 weeks. Then we do some clinical and functional measurements before surgery and 4 and 8 weeks after surgery. Now I'm going to give you a little bit of details on the clinical component of this, the nutritional, it's all clinical, the nutritional component of it. At the time of consent, what we do is we just give patients a 3-day food record and explain to them how to fill it out. When they come to their first appointment, then a dietitian sits down with them and really just does a basic assessment. We look at protein and energy requirements, we estimate it based on their food record, and we look at their food choices. Then we devise a nutritional care plan for these patients. We look at their nutritional requirements, and we're lucky we use indirect calorimetry, so we try to be pretty accurate. And we give them protein at about 20% of their total energy expenditure. And this works out to be about 1.2 to 1.5 grams per kilo of ideal body weight. So our nutritional care plans are based on these requirements. They're based on the food choices that they're making. So we try to tailor these care plans to be really personalized, so based on the foods that they actually eat, to be really, really practical. We look at biological indices like A1C, and we have bioelectrical impedance to look at their body composition. And of course, we consider their medical history and clinical status. So what do these nutrition care plans really look like? We focus on meeting energy requirements, but mostly we really focus on meeting protein requirements. That's a big part of this nutrition care plan. The second biggest part is managing cancer-related symptoms that affect food intake. So as you know, and Carlotta talked a lot about this in her presentation, that if we can give patients all the advice, all the nutrition suggestions, but if there are barriers to intake, they're not going to be able to eat. So we focus on things, if you know you need to eat more protein and you can't do it, why can't you do it? So we get into managing the actual symptoms. If it's diarrhea, we manage diarrhea. If it's constipation, we manage constipation. If it's depression, we give them the anxiety reduction strategies. And I've had patients say to me, Chelsea, you can give me all the protein, and we use these whey supplement sachets. You can give me all the sachets that you want, but I can't do it. Not up here yet. So they need some strategies to help improve oral intake sometimes. We also can focus on controlling blood glucose and, of course, optimizing body composition and nutrient-dense foods. So that is really what the nutrition care plan looks like. That's what they go home with. It's tailored completely to their needs. I actually take their food record and I make them add foods to it to tell me how they're going to improve it after I've taught them how to do it. So it's really patient-centered based on what they know how to do. We also give these patients a whey protein supplement. supplement, and we give the supplement in a quantity that meets their dietary needs. It's really to supplement protein needs. So if we assess that the patient needs 100 grams and they're only eating 90 grams, we give them 10 grams of whey protein to supplement that need. On average, I have to prescribe 20 grams of protein to the average patient. So that tells you right there that these patients have a protein deficit leading up to surgery. They're not meeting their protein needs before surgery. Why do we use protein, or whey protein specifically? It's rapidly digested. It's rich in essential amino acids, especially leucine. And leucine has been found to independently stimulate protein translation. It has immunomodulating properties. There's been a number of human trials, mostly in cystic fibrosis, looking at giving whey protein supplements and showing that we can actually increase glutathione, the most important intracellular antioxidant, or reduce cytokines. So this is one of the reasons why we give whey protein. It's also really quite readily available. It's pretty easy to access. The other reason we use whey protein is to support muscle protein synthesis after exercise. Remember, our patients are doing an exercise program. So we tell them after they've done their exercises, within 30 minutes, they take a protein shake. And it's generally accepted that exercise is the main anabolic stimulus, but nutrition augments this effect. So we need to give them the substrates, the amino acids, in order to optimally gain this protein accretion before surgery. So we give them optimal protein to help with their post-exercise routine. So that's kind of the nutritional component. Usually it's part of a whole trimodal program, but I'm going to just take a few moments and a few slides to talk about a nutrition-only study that we did. So this is a study that we just kind of recently finished. It's not published yet. I think it'll be published in a few weeks. This was a pilot study, double-blinded, randomized controlled trial, where we gave patients, we randomized them either to nutrition counseling and whey protein, which is really nutrition prehabilitation, or we randomized them to a nutrition counseling and placebo group. So 4 weeks before surgery, these patients either did nutrition prehabilitation or we just gave them some counseling and they took a placebo supplement. Then they have surgery and they continued the exact same program after surgery. And this occurred for about 4 weeks before the surgery for the pre-op part, and we actually only have data up to 4 weeks after surgery. And a 6-minute walk test was our primary outcome. If you look at our patient characteristics, there are no significant differences between groups, but I just want to highlight, Dr. Kylie kind of highlighted this as well. Here's our percent predicted. So this is the percent predicted 6-minute walk test based on age and gender at baseline. These patients should be able to get 100% based on their age and gender. We have 60%. This means these patients are only reaching 60% of what we predict they should be based on their age and gender. They're not very fit. This is their functional capacity. They're not fit before surgery. This is complicated to use both things here. So let's look at some results. This is our preoperative period of our nutrition-only study. This is the change in 6-minute walk test from baseline to before surgery. Or in other words, do patients gain functional capacity while they're waiting for surgery if they're taking either of these programs? Well, the placebo, we didn't see much. They didn't really gain any functional capacity. But with the whey protein, we actually found a mean improvement of about 21 meters. So on average, these patients were able to meet a clinically important improvement in functional walking capacity before surgery. Now, the real question is, does this translate into postoperative recovery? Do they recover earlier? Maybe they've improved beforehand, but do they recover earlier? Well, I have some preliminary results. So let's take a look at the summary of the evidence so far. If you look at the y-axis here, this is the distance, the mean distance these patients were able to walk in 6 minutes at baseline, pre-op, and 4 weeks after surgery. Here's our prehabilitation study. This is a standard control study. And this is a nutrition prehab study, the one I'm talking about, our whey protein. So we have 3 different studies here. If you look at the red bar, unfortunately we did not have a baseline, but we do have a pre-surgery 6-minute walk test. These patients did not receive prehabilitation. They did not receive rehabilitation, no intervention, just standard of care. But they are ARAS patients. They are on the ARAS pathway. As you see, at 4 weeks after surgery, these patients, their 6-minute walk test is pretty low. They have not recovered their pre-surgery functional capacity. Now, if you look at our trimodal prehabilitation or our nutrition prehab in the blue and green, they follow a pretty similar pattern, these groups. Both groups are able to gain about a clinically important 20 meters before surgery, and they're both able to recover their functional walking capacity earlier than our standard of care group. That's way down there, the lowly group way down below, without any treatment. So we can see that even just nutrition alone with whey protein was able to kind of support this earlier recovery because we built this reserve before surgery. Now I want to give a little caution because I'm really excited about these results, but if you remember at the beginning, I only had 20 patients. So this is really preliminary data. So we can't kind of run home about this nutrition prehab study yet, but what we can conclude is that nutrition is a really integral component of prehabilitation. I think that's very evident. Dr. Carly showed you slides of exercise-only prehab, unsuccessful. Nutrition-only prehab, you know, pretty promising. We need more trials, but it's pretty promising. So what we can conclude right now is that nutrition is a very much integral component of prehabilitation. So just a few summary notes. I want to really stress that nutritional care begins at cancer diagnosis and continues into the postoperative period. So we really have to get on this bandwagon of not just correcting deficits, of optimizing the patient. So I know we can't optimize every single patient that comes through the door, but we should definitely start with screening and targeting the patients that are at nutrition risk, not just severely malnourished patients. Secondly, I showed you some preliminary evidence that nutrition really is an integral component of surgical preparation and an integral component of prehabilitation. And lastly, and I think Dr. Carly said this, Lena's going to say this, just want to really drive the point home that there are patient risk factors that are modifiable, that we can change, we can modify these risk factors, and actually improve functional recovery before surgery and accelerate the recovery after surgery, improve functional capacity and accelerate recovery. So that's it. Thank you.
So good afternoon. I'm very pleased to be talking to a group with nutritionists because as we've been talking about repeatedly that the role of exercise and nutrition is intrinsically linked, and I think the more that we communicate between the professions, I think ultimately the better it is for all patients involved. So today I'd like to talk a little bit about the role of exercise in cancer prehabilitation, and I call this talk Bike Not Bed, and for a very good reason, and I'm going to highlight that in a moment. So this is the traditional advice that most patients are given. You should take it easy. You need to rest. Sleep is what you need. Put your feet up. So this is what the majority of cancer patients are receiving for advice from the medical professionals. But just what's wrong with this advice? Although rest is important for the patient, sedentary behavior can become a vicious circle for the cancer patients, and it happens very quickly, and I'll show you this in a moment. And the effects of physical inactivity can further impact the patient at a critical time point in their disease trajectory. These are the patients who need the vicious cycle of sedentary behavior the least. So we've learned a lot from bed rest studies. So what happens to a patient when all of a sudden they stop being active or they become even less active than they were previously? So inactivity very quickly results in physical deconditioning and a negative health status. And this can happen we see this repeatedly in a large majority of studies and in a large majority of groups. So just to highlight a little bit what's happening with these individuals, 10 days of bed rest results in diminished muscle mass. I think this is how it works here. Muscle strength and physical function, and these are healthy older adults. These aren't even cancer patients. 10 days of bed rest results in substantial loss of lower extremity strength, power, and aerobic capacity, again in healthy adults. These are 10 days of bed rest. 9 days of bed rest in young men results in insulin resistance and changes gene expression that negatively affects mitochondrial function, and which were only partly normalized after 4 weeks of retraining. So the effects of the detraining or the bed rest is actually stronger than the stimulus to retrain these individuals. And that's extremely important because, as Franco had mentioned before, these patients have already they're in a state of metabolic disturbance. 5 days of bed rest results in endothelial dysfunction and elevations in diastolic blood pressure in healthy adults. And 5 days of bed rest results in 67% decrease in the insulin response to glucose loading in healthy adult subjects. So these effects happen extremely quickly. Individuals at risk for developing type 2 diabetes are subject to a disproportionate aggregation of existing low-grade inflammation. Again, these cancer patients have this due to their condition, and what we say when we're telling them to stop exercising, stop moving, and get into bed and take it easy is we're making their situation worse. So we're priming them to be poor surgical candidates even before we start. And so what this all says is that the effects of physical inactivity are critical for the surgical process. And inflammation and loss of physical function is already of concern in these individuals. So what do we do about this? So what's the take-home message that we can get from these studies? As long as the patient is medically cleared, and that's important, and has no contraindication to exercise, we should actually be encouraging physical activity and not encouraging bed rest in these individuals. So granted, if somebody doesn't have severe case anemia, they have no respiratory conditions, they have no uncontrolled cardiovascular complications that happen concurrently, we should be encouraging the use of physical activity. So, but the biggest question is, what can we do? There tends to be a lot of feedback saying you should exercise, but that's a very vague notion for the majority of individuals. So what the benefit of entering into a program like what we're doing at McGill in prehabilitation is we're giving these patients the necessary tools and guidance to allow them to do safe and effective physical activity. So exercise in the cancer patient. So people with cancer, they can safely train and benefit from regular exercise similarly to those that do not have cancer. So where do we see these benefits occurring? We see, we see that they can gain cardiorespiratory fitness. We see muscular strength and endurance improved by use of physical activity, flexibility, bone health, and this is extremely important for some of the treatments that are being offered to cancer patients. Body composition, which Chelsea had alluded to previously, well-being, so reduction in anxiety, improved sleep patterns, increases in energy levels, all of which are readily needed by cancer patients, and the improved ability to perform activities of daily living. And in the pre-surgical process, these are all extremely important components to reduce stress, to make them feel better, improve quality of life. And if we send them the wrong message, we're taking away what they need prior to the surgical process. So we have different strategies for exercise. Sorry, I guess I'm taller than you a little bit with your high heels. Mine are flats. We have different strategies for exercise, and we hear about exercise a lot, but unfortunately people don't do them. We don't have the support system that's available, and the funding just doesn't exist in our society. We don't have the culture for a lot of the exercise or the messages that we would like to deliver. So some of the exercise strategies that do exist include prevention, which we all would love. We would love to target people before they become ill. But unfortunately, that's not the case in 99.99% of individuals. We have prehabilitation, which is an acute phase. It's a defined period of time. We also have rehabilitation, which also is an acute phase where it's occurring after. It's a defined period. So for example, after surgery, that we're in a rehabilitation period. Could be also, for example, in the case of having an injury and seeing a physiotherapist. There's an acute phase in the rehabilitation process. We can have it during treatment, and more cancer clinics are suggesting the use of physical activity during chemotherapy or radiation therapy, given that there's no contraindication again. And we're also talking about long-term lifestyle changes. after somebody survives cancer, we don't want to see them back again. And physical inactivity, we work with colorectal cancer patients. Physical inactivity is a high risk factor for redeveloping cancer. So we don't want to see them back. So we want them to make positive lifestyle changes in order to reduce the risk of redeveloping cancer. So ideally, all of these should be part of the optimization of health across a lifespan in populations. But unfortunately, we don't always capture people in those periods of time. So most of the time, we're seeing them when there's something wrong with them. So this came out of the American College of Sports Medicine Roundtable on Exercise Guidelines for Cancer Survivors. And if you're from Edmonton, there's some excellent work at University of Alberta with Carrie Cornea that looks at the use of exercise in cancer patients. And he was one of the people who participated in this roundtable. So you're basically looking at physical activity and cancer control framework. So where we see exercise happening often is in the pre-diagnosis section, in the pre-screening and then screening phase. And then in the post-diagnosis, we have the pre-treatment, the treatment, the survivorship, and in the end of the life phase. Yes, we actually exercise train people in palliative care to preserve the quality of life for as long as they have it. And hopefully, the majority of the patients that we see are not going through palliative care, but that are considered survivors. And we're encouraging those survivors, due to the negative effects of the chemotherapy and radiation therapy, they need their own special type of exercise rehabilitation. Because yes, it affects the cells, the cancer cells, but it also affects other cells such as muscle cells. So we really need to encourage exercise training in that population as well. So when do we intervene? Ideally, as early as possible and before chronic health conditions become an issue. Every time we turn on the TV, we are looking at reducing cardiovascular disease risk. We're looking at prevention of cancer. We're looking at prevention of osteoporosis. We're looking at prevention of multiple conditions. But most people think it doesn't affect me until it affects them. So most of the time that when we see people, we're seeing them in a treatment or in a diagnosis phase. So in reality, the intervention is considered when that patient is diagnosed. The majority of research to date focuses on the rehabilitation component, which may not be the most effective period to intervene. Why? I'm going to ask that first before I ask when. When you're trying to get somebody to embark upon lifestyle changes, often we have to, or most often, we have to deal with barriers. Why are they not doing something? And very important barriers to making health changes in their lives are things like, well, I'm stressed or I'm anxious and I'm facing cancer diagnosis and I don't know what's going to happen with me and I don't know what's happening with my kids or my marriage or my house or whatever. That's not the time where you say, hey, let's talk about exercise. They're tired after the surgery, they're fatigued, they're not thinking of it. They're not thinking of what's happening to them in terms of exercise. They're thinking of the immediate. So what we're thinking in terms of when we try to get people to change is when they feel like they want to make a change. So prior to going into surgery, they're more receptive because this is the time they're waiting anyway. Nothing's been happening. They're not recovered. They're not worried about affecting hurting themselves or their surgical wounds or anything like that. If you target them before, they feel proactive. I want to do something. I need to change something. I need to get off the couch. I need to do something. That's the period of time that we're targeting. And that's an important period of time. So that answers my when question. So we work in rehabilitation, so it's an intervention prior to a major physiological stress such as surgery. It's about approximately 4 weeks in length and takes place between the time of diagnosis and the time of surgery. And this is the period of time, like I said before, where the patient may be the most receptive to intervention. They feel like they can do something, and it may be in a sense, and this is probably very anecdotal, but it's a period of time where they feel like you're giving them a choice to be involved in their own healthcare. They're being dictated everything else to do. Here's a chance that you as a patient, you can be involved in your own healthcare. So how can exercise play a role in prehabilitation? Most of the time, I teach in the Department of Kinesiology, and the majority of our students are athletes or have been athletes. And when I tell them that exercise is nothing but a physiological stress, they kind of roll their eyes at me until I further explain this. But what happens when the first time you embark upon a new exercise routine, it doesn't feel very good. Most of the time, we don't really like it. You're sore the next day. It takes you a while to get used to it. But once you've done it for 4 or 5 or 6 times, then you start to say, hey, you know what, this feels pretty good. I'm getting used to it. And what used to be very difficult or caused me pain the next day, now all of a sudden feels good and I can do it. And I don't feel as winded and I don't feel as terrible and I don't feel as whatever. So what have you done? The first session, you've caused a big stress on your body. And your body has to learn to recover from that stress. What is surgery? It's a big stress on your body. And if your body is used to recovering from stress, you're better able to recover from the stress of surgery. It's a perturbation of basic homeostasis. And so if we look at this, what we're doing to the patients, this is probably the best time. We're preparing them for a big stress. Not to say that surgery is exactly the same stress, of course not. But if we can make them better prepared physically to endure that stress, all the more power to them. Yeah, you're right, it's kind of hard with all these different buttons. So what we're basically doing is we're teaching the body to learn how to adapt to an applied stress, and that's called training. We do it when we train people, we're doing it prior to surgery. And exercise improves the functional capacity and the physiological reserve in these individuals. And that's exactly what we want before surgery. We want their bodies to be able to handle the stress. So we've seen this beautiful, lovely figure. We love this figure in our lab. So what we're basically doing in the pre-surgical period is here we're improving their level of functioning. We're improving their physiological reserve because we're physically training them. And we're not saying we're sending them to the gym and doing very intense exercise. We're very much tailoring the exercise to the needs of the individual. And the less of a reserve they have, the less in shape, and we've seen this from Dr. Carley, the more you can get out of them, the less of a stimulus you need to elicit a response. And that's extremely important in these individuals. So when we look at an individual and we see somebody very frail, to me I see gold, because a little stimulus gives them a big return. So these are the patients we really need to be concentrating on. So basically what we want to do is we want to get from this shape to this shape. And so how do we do it? We do it with the exercise in combination with the nutrition and anxiety reduction techniques for the first 4 weeks prior to surgery. So this is, I'm going to just share a little bit of our experience at McGill. It's quite novel. So just what our experiences are, and it's in a period of development, so you're going to see like a little snapshot of where we are and where we would like to go with this program. So basically we do 4 weeks of multimodal prehabilitation, so the time of diagnosis to the time of surgery. And it's our goal to improve the functional status. That's it. We want to improve the functional status prior to surgery to make them a better surgical candidate. We want them to recover faster. We want the stress of surgery to be less on them. And so this is how we're trying to improve that. So this is basically the type of program that we get. At the moment, we predominantly use a home-based program. And we're starting to incorporate supervised exercise sessions, 1 session per week. So we look at a combination of aerobic training. We cater to them, and I'll talk a little bit about the Borg scale. But we use an exercise intensity that's unique to them and their needs and their fatigue levels and where they're at in their training process. And what we do is we find activities that they like, that they already do, that's easy for them to manage. And in our lovely Canadian winters, it's a bit of a challenge during the winter times, but we try to find solutions to possible barriers so that they stay active. So we can suggest things like, as long as there's no catheter or any reason why they can't swim. We look at cycling. Granted, there's no balance issues. We look at walking. And we usually do 4 to 6 on a Borg scale. So basically, and I'll show again, on a scale of 1 to 10, that exercise would represent either between a 4 to a 6, so moderate to vigorous intensity exercise. We do resistance training, so we teach the patient the type of resistance training, and we supply TheraBands. So it's a very inexpensive, very mobile use of resistance training. We target the major muscle groups: arms, shoulders, upper back, lower back, abdominals, upper leg, and lower leg, to preserve the functional status, their quality of life, their ability to move around. The flexibility training, so we hold stretches for about 20 seconds to be performed after the resistance training. So all the exercises are reviewed by the kinesiologist on a regular basis, and the thing that's nice about the Borg scale is that it self-adjusts. The more trained you get, the harder you have to work to maintain the same exercise intensity. We also encourage, I'm put here, wrong pointer. It's not just exercise, but it's really the nutritional supplementation and the stress and anxiety reduction techniques that really work hand in hand through the whole process. Again, what Chelsea had been talking about before is that there is an anabolic window post-exercise, and studies have shown that if you time your protein consumption with the cessation of exercise, that it maximizes protein uptake, and this is exactly what we want in these individuals. So again, this is the Borg scale I had talked about before. So basically, we give the patients this Borg scale to take home with them, with the pictograms and the color representation, and we don't want them to work in the very intense activity. We don't want it to be a shock on their system. So we want them to ease into the program where they feel comfortable, avoid injury because they're not used to the type of activity. And so it's important to maintain an overload. So meaning that when something starts to become, instead of a 4, 5, 6, starts to hit a 1, 2, 3, you're not training anymore. You're not applying a stress anymore, and that's an important concept. You need to have the overload. And this is one of the reasons why if people come into the program very fit, we really have to work on adapting a program to them that keeps the stress, the stress stimulus on, and not just say, okay, well, you can take it easy now. Because if you start to take it easy, then you start to get into either a plateau effect or a detraining effect, which is exactly what we don't want to have occur. The Borg scale is also really good because it allows for progression, and it also, this is important for the cancer patients, it allows for the patient when they don't feel well, fatigued, or during chemotherapy, where they can self-adjust so that it's not too much work for them on a given day where they feel more fatigued. So as they become more fatigued, less work is required in order to maintain that 4 to 6. So it's very self-adjusting. So the biggest question is 4 weeks, is it enough? I used to train train type 2 diabetic patients, and often we saw 8, 10, 12 weeks in our studies. So that was my first question when looking at the prehabilitation program. So I've written here, most exercise training programs in the literature, at least 8 weeks. So is 4 weeks of enough of a stimulus to improve the functional capacity in these individuals? So this is the paper by Chelsea. We've seen this before, but here we have this 4-week period, and we're seeing major improvements happening in the prehabilitation group. So obviously, because this is their trajectory, we're seeing improvements here, and we're seeing improvements that are occurring here. So obviously 4 weeks is doing something for these individuals. This is another study one of my students is finishing putting together. And this again here, this is 4 weeks of a prehabilitation versus a control group. So they're not receiving anything pre-surgery. Here there's a significant increase in the 6-minute walk distance from baseline to the pre-operation. So again, we're seeing something here. And this to me is very important because so many of the, I guess one of my biggest challenges as a kinesiologist is getting people to exercise. And what we're able to do in this 4-week period too is we're getting people in the prehab group. These are 40% of the population and 34% of our subject pool that are meeting the basic ACSM guidelines of 150 minutes of moderate to vigorous intensity per week. That's pretty generalized guidelines. This is very typical of the population. About 30% of the population in this age group, between 30 to 40%, meet the daily recommendations. That's kind of sad because you're looking at it and you're about 70% 60 to 70% are not. So what we're able to do in the 4 weeks is we're getting this group, the prehabilitation group, it's almost 70% that are meeting the daily recommended guidelines, where in the control group, there's a little bit of adjustment, but not much. So we are successful in this case, and I've said it here, 4 weeks of prehabilitation is sufficient to improve functional capacity as represented by that 6-minute walk test, but also 4 weeks is also sufficient to initiate changes in exercise behavior in the pre-surgical period, and that's extremely important, because if I can give them any sort of message to start to change their behaviors, if they're receptive to it and they're doing it, hopefully that this is something that's going to maintain in the post-surgical period and maintain as a lifestyle choice as they become a cancer survivor. So can we do better, though? So now we're looking at incorporating supervised exercise programs, because the one that I had shown previously was not supervised. That was a home-based program. This is prehabilitation with and without supervision. So this is our regular prehabilitation, but we're starting to call this like super prehab, where they come in 1 time per week, or prehab plus. They come in 1 time per week where they really feel the support of the team. We're able to review the exercises that they're doing. We're able to adjust the intensity. We're able to give them feedback on how they're performing the exercises. We see that they're doing it because we can see improvements. We can quantify it in the lab ourselves. And we're seeing even faster improvements. So here, post-operatively, within 4 weeks in this group, the majority of the patients are back to their baseline. And that's very important, because if they're recovered, these are the people who are going to be able to have chemotherapy perhaps earlier, at an earlier stage, which is extremely important for these individuals. And if you think you're taking somebody who hasn't fully recovered from surgery and then you're going to give them the added insult of chemotherapy on top of it, you want them to be in as good a shape as possible. You want them to be recovered. So what we're hoping to do is get them in better shape so that we can initiate further treatment and have them be not already going into chemotherapy at a disadvantage. So this is the same study that we just saw. These are the supervised versus the home-based programs, and this is the number of patients, the percentage, and this is the recovered. So the supervised, you have 32% of the people that are below baseline, but more importantly, at baseline or above baseline, you have 68% of the individuals. In the home-based program, you still have 48% who haven't fully recovered yet, and 52% that have. So what we're saying is that prior to our concern or initial reservations about having them, people who are in this period of their time, come to the hospital and do all this stuff, I didn't put a slide, but the adherence is 99% prior to surgery. So the patients are sticking with this program. So what our preliminary results say to us is that minimally supervised exercise sessions, it's 1 time a week, before surgery and during the post-surgical follow-up has had a positive impact on achieving a faster return to baseline functional capacity. I didn't show you about the post-surgical follow-up yet. A greater portion of 68 versus 52 were at or above baseline before at 4 weeks versus 8 weeks. And a faster recovery, which I've said before, will allow for a faster initiation of adjunct therapy, such as chemo. So what are our next steps? We really want to know what works best for each of the individuals. And as we start to become more patient-centric, which I think is important, we need to evaluate what the needs of the individual are. Maybe some of the patients don't want to come in. Some of the, for example, some men who are very fit or some women who are fit, they might not see the need. They might say, I'm able to handle this on my own, I'm good, I'm fine, I feel good. Okay, then they can continue the training that they've been doing in the past, and we'll support them through that. The people who need more of a support or need to come in and need to feel more watched or supervised, maybe they need to come in not just once, but maybe 2 or 3 times a week. So we have to take a look and see what are the needs of the individuals, what are the type of exercises that they need to do, how do we support them? Because if they like it, the odds are of them continuing the program as a cancer survivor are dramatically increased. We're also thinking about putting together a questionnaire to better determine the needs of each individual. What do they like? What do they not like? What works for them? What doesn't work for them? And to reevaluate our program accordingly. I'm a big fan of the concept of dose. As exercise, there's a movement in the United States and coming into Canada and in Europe about exercise as medicine. We have to understand the dose. One of the studies that Dr. Carly had shown earlier about having very intense exercise, maybe that dose was wrong for those individuals. A drug can be a good drug, but at a too high dose, it has negative effects. And the same thing can happen with exercise, and we have to start thinking about that. We have to understand some of the mechanisms. How do exercise and nutrition interact? As somebody who comes from the field of diabetes and exercise management, it's really important to understand the mechanisms behind insulin resistance, protein anabolism, protein catabolism, and how can we support net positive protein deposition. We also want to look at the feasibility of prehabilitation on more frail populations. Who can we exercise and to what extent? And exercise as a means of diminishing risk of future cancers of developing. And looking at the long-term effects, for example, of chemotherapy. How do we manage those long-term effects as well by use of exercise?